Hey, welcome back to EMS Abounds AEMT chapters. This is, as you can see, chapter 42, Multisystems Trauma Resuscitation. I just did chapter 30 on the EMT book, which is basically the same. This goes a little more into treatment because, we've got to talk a little bit about fluid therapy and whatnot for AEMTs. But the majority of treatment and decision making is the same, whether you're an EMT or a paramedic. Okay, do I stay and play? Do I load and go? Do I fix something? Do I not fix something? Who is a trauma patient? Who is not a trauma patient? Who goes to a trauma center? Who can go to a local ER? So hopefully at the end of this, we'll clear a few of those things up. All right, so we look at a definition first. So one or more injuries, significant injuries to one or more body systems. And when we add that one or more, we start to talk about increased mortality. Okay. We need to look at the overall impact of this trauma on the patient. First and foremost, life threats. One of the resources that I've used in the past is a textbook for ER doctors, the ER doctor program at UCLA, University of California at Los Angeles. And they talk about the fact that intra-abdominal trauma, so, one of the main multi-trauma issues, gets missed a lot by ER physicians because we tunnel vision in on the gross, exciting, sexy injuries, whatever, or because the patient doesn't complain of a lot of pain due to either their age or the fact that they've medicated themselves with alcohol, narcotics, benzodiazepines, etc. And so they don't have the symptomology that we kind of would expect. Do not forget your ABCs. They come first. And then we need to think about transporting to the closest appropriate facility. Not the closest hospital, but the closest appropriate. So we have to do a scene size up on everyone. Right, this is from chapter like 5 or 6 or whatever it is. As you get the dispatch, you get the tone, you get the call info. What are you starting to think about, right? Is the scene safe? Am I going to need additional help? And as you walk up to the vehicle, the ladder, the motorcycle, whatever it is, what do I see, hear, and smell? Okay. Do I see a safety issue? Do I smell gas, blood, vomit? Right? Do I hear moaning, groaning, stridor, grunting? Right? Man, consider stabilizing the head and neck. Multi-trauma patients should have their head and neck stabilized, right? I mean, if we're taking them to a trauma center, they should have a collar on and be motion restricted, which is the way we're going now, which I agree with. If you have a broken femur, do you not think that maybe that's a distracting injury, right? So sure, somebody who's walking around the car's totaled, and they don't have any complaints and they're walking, talking, and feeling fine, then sure, you want to rule out C-spine, go for it. You got a guy who's a train wreck and or unresponsive, stabilize the neck, put a collar on him, right? Do your ABCs, airway, breathing, circulation. I like March, and this is one of the ones the military uses. Massive hemorrhage, airway, respirations, circulation, and hypothermia. Okay. So rapid trauma exam, March, back to March, massive hemorrhage, airway, respiration, circulation, and hypothermia. You got to remember the fact that what's going to kill them first is what you need to address. If it's a little bit of bleeding and they're snoring, then you fix the snoring. If it's a lot of bleeding and they're snoring, you fix the bleeding, right? I mean, my wife will snore all night, 8 hours, and she'll wake up no problem, right? A lot of us have family members that do that, and they wake up every morning if we don't put a pillow over their head. So bleeding though, massive bleeding, right? And then what's going to kill them? First 1 to 2 minutes. Then we do our head to toe. What's going to kill them in the next 5 minutes, right? Head, neck, chest, belly, pelvis, legs, arms, and back. Don't forget the back. I've always been nervous about that doing intercepts. I climb in somebody's truck and they're all strapped down, collared and boarded even today. And I look at them and say, how'd the back look? And you see this little flinch. Fine. No, it's not. You didn't even look. Start unstrapping him because I don't want to miss a hole that's going to kill the dude, you know. So package is indicated by that mechanism of injury, right? So do they need to be moved on a scoop because it's the only way you can move them? Scoops are better than backboards, right? And because they don't put pressure on the spinous processes and on the skin. And scoops are great, and they're easy to get in underneath them. You don't have to log roll, all that stuff, and it's easy to get them off. So do you need to scoop them? Do you need to do a bunch of splinting? Okay, and then transport appropriately without delay. So minimizing on-scene time. I think it was Dr. Crowley from Baltimore Shock Trauma who came up with the golden hour. Right, and the golden hour states that your serious trauma patients have to be in the OR on the table, ready to be cut open within 1 hour if they're going to survive the event. Well, turns out that's not true. Iraq and Afghanistan have proven that. The studies there have shown that of your most seriously injured patients, okay, about 10% of them are going to die in the first 6 minutes. It doesn't matter. They could be shot in the OR, next to the OR table, land on the OR table. 10% of your most seriously injured are going to die in 6 minutes. The next 54 minutes, so that first hour, you're going to lose another 10%. Okay. The next big chunk of time comes over 6 hours with airway and shock and infection and whatnot. Okay. So it allows us to take the patient to the appropriate facility. And I read an interview with the good doctor, I don't know, 5 or 6 years ago, and they asked him what study, because now everything's evidence-based medicine, what studies he based the golden hour on. He goes, we didn't do studies back then. He goes, somebody asked me one day, hey doc, what do you think the optimal time is to get a patient to the OR? And he goes, I don't know, I pulled it out of my ass. I said an hour. And he goes, I never meant it to become the word of God. He goes, but it has become that. So the golden hour. Minimize on-scene time though. Remember, some of your transports are kind of long. I mean, I have an hour and 15 minutes to a trauma center from here. Work as a team. Teamwork. You need a team leader though, okay? If you take PALS or ACLS, a lot of those first videos are geared at the qualities of the team leader, right? Almost the worst team you could have are 2 headstrong paramedics who don't communicate. They're both going to be going in different directions, telling the same person to do different. It's a nightmare. Okay, so teamwork, team leader, teamwork, assess for life threats, and get ready to go. ABCs, cannot stress those enough. I had a motorcycle accident this summer. 3 paramedics on scene, my partner, another paramedic from the other truck, and an AEMT, and everybody was geared in on this femur. And, you know, stop, everybody stop. And the AEMT is trying to get him on a board. I'm like, stop. Let's step back a minute. Let's get back on task. And the way I did that was going, okay, everybody, how's his A? Well, he's kind of yelling at us. Okay, so his A is good. How's the B? Well, he seems to be breathing okay. Well, I've listened to his lung sounds. His lung sounds are good. How's his C, right? Do we have a blood pressure yet? No, let's get a blood pressure. Okay, so sometimes you just gotta, boom, stop, reset, and go ahead, go again. Okay. Scene size up, our priority is safety. Ours, yours, his, everybody's, okay? Don't risk anybody's life. 1 patient's bad enough, 3 are even worse. Call for extra help if you need it. 1 critical patient at a time. Yeah, that's a great idea if you live in Boston or you're in Manchester, New Hampshire, right? I'm in Manchester. I've got 4 911 trucks dedicated to the city, and there's like 3 transfer trucks running around. That's easy. I got 2 car MVA and 2 status ones. I can get more help. Right now, I might wait 20 minutes for an extra ambulance. So we may have to split up. My partner goes to one, I go to one. Okay. Who's going to ride with you? Who's going to drive with you? You know, there are times where you need multiple people in the back. Okay. ALS. Here's something to think about. This is an AEMT program, and people go, well, I'm ALS. You're partly ALS, okay? To quote Clint Eastwood, a man's got to know his limitations, right? As an AEMT, you have a limited advanced life support capabilities. You know, yes, you can start that all impressive IV or IO, but for a trauma patient, that's all you can do, right? So for ALS, when you're thinking this, you got to think medics, right? We can do surgical airways. We can stick needles in the chest. In theory, our assessment skills should be better. In theory, we've got more experience and we can run things, but it's not always the case. I know that. But if available, have a medic start. You can always cancel them. You can always cancel helicopters. Okay? Go to your closest. If you don't have an airway, go to your closest airway provider. It might be a medic, might be a helicopter, might be a small local community ER. Okay? Where should you go? The most appropriate facility, which might be that community hospital, but it might be the trauma center. How do I get them there? You know, if I have a 20-minute extrication and I have an hour and 10-minute transport time, then, you know, that's an hour and 10 and 20, that's an hour and a half, plus about 10 minutes to package. And we're talking an hour and 40 minutes. Maybe the helicopter is the best idea. In case you didn't know, motorcycle collisions can result in multi-systems trauma. Also, being ejected from a vehicle completely or partially, being struck by a vehicle is not a big shock, right? Even my new little Hyundai that weighs 2,000 pounds outweighs me by 1,800 pounds. So getting hit by that would suck. Falling, depending on what you read, you'll see 20 feet, 3 times the height or 20 feet, 3 times the height or 18 feet for adults. You'll see twice the height or 10 feet for kids. Motorcycle and rider, they go down and they get tossed off their motorcycle. Any sort of motor vehicle impact over 40 miles an hour, any explosion, and penetrating trauma, proximal to the elbows and knees, right? So head, neck, chest, belly, pelvis, thighs, upper arms, because those are where the organs and the big vessels are. Mechanism of injury for stabilization, yeah, like I said before, if you think this is a multi-trauma patient, you should probably stabilize that head and neck. I beat this one up. ABCs, right? March, whichever you prefer. You got to have teamwork. You got to have the team leader. And what I like to do, if I'm the team leader, then I'm assessing the patient and I'm making the decisions. Everybody else is my helper. Next call, I'll be the helper. Okay. You got to think airway and you got to have suction ready for all multi-trauma patients, but especially with face or neck. And you need to have these things at your side when you're dealing with this patient, whether it be suction or BVMs or airways, etc. It doesn't do you any good if they're 50 feet away in an ambulance, okay? If you can't get an airway, go to somebody who can. Continue to suction, continue to try to hold their airway open, continue to ventilate them as best you can. Keep in mind, everything you have just assessed can change in the blink of an eye. Okay, there are patients that I will ride to the hospital with my hand on the radial pulse the whole ride. Okay, or I have my hand on their chest, feeling chest rise and fall. Okay? Capnography on these trauma patients are great because not only can it tell you whether they're retaining CO2, but you can look up and see them breathe on the monitor. You know, so if you have to ventilate, ventilate. But consider why you have to ventilate, right? Is it brain? Is it chest wall? Do they have a tension pneumo? Do they have a spinal cord? right? You got a spinal cord injury and they're not breathing. Guess what? That's C1, C2. Have the blood pressure yet? Because if you don't, you're going to be surprised when you find that they are completely vasodilated from the spinal cord injury and they have no blood pressure. Right? You got to cover the chest wounds. If you think they get a pneumo, you got to have somebody poke a needle in their chest. Pulses, skin, cap refill. Are we perfusing? External hemorrhage, tourniquets, hemostatic dressings. Okay, keep them warm. Cold kills trauma patients. A drop of 2 degrees increases their O2 demand, something like 90%. Okay. If they start to shiver, it increases at 700%. Med flights, helicopters, they have a couple of benefits. One, a lot of times they'll have blood products with them, right? Dumping a bunch of normal saline and or ringers into a patient who's bleeding, has uncontrolled internal hemorrhage, all that does is dilute the blood they've got. Makes them bleed more, it breaks down clots, it doesn't carry oxygen. So a lot of times these folks have blood, that's handy. A lot of times they can do advanced airways with chemical assistance, right, RSI. And there's 2 sets of critical care trained providers, usually a nurse and a medic. And rapid transport, right? If you're going to do 140 straight as a crow flies, that's a lot faster than doing 60 as the highway curves. Now, level 1 trauma centers is what is recommended nationally. If you can't get to a level 1, go to a level 2 if you can. Level 3s are your next option. So like here in the southeast corner of New Hampshire, we have a level 3 at Wentworth Douglas and Dover. We have a very good level 2 in Portsmouth. In fact, their neuro is phenomenal. The helicopters around here fly brain injuries into Portsmouth instead of, all the way to Portland, Boston, Dartmouth. That says something. Our only level 1s here are Portsmouth, Boston, Portland, and Dartmouth. Critical patients. This slide, should not be all that mysterious to you. Bad airways, bad ventilations, trouble breathing, air in their chest cavity, right? Flail segments because the chest wall is not moving together. Therefore, you don't have as much pressure differentials on inhalation and exhalation. You have decreased tidal volume, decreased minute volume. You have hypoxia. Internal, external hemorrhage, altered level of consciousness. Those penetrating traumas proximal to the elbow or knee, right? A gunshot wound to the calf is bad, but a gunshot wound to the thigh is worse because the blood vessels are bigger. Amputations of hands and feet, significant burns to go with it. Trauma patients with burns should go to a trauma center. Trauma patient with injuries and burns go to a trauma center. Trauma patients who have just burns go to a burn center. Right? 2 or more long bone fractures. Right? You break a pelvis and a humerus. These are proximal to the elbows and knees. You break a tibia and fibula down low, it's just an ankle fracture, all right? But it's 2 bones, so those don't count. You break 2 femurs, that's a lot of pressure. That's a lot of kinetic energy that you've absorbed. And the big vessels run next to those femurs. The pelvis, full of blood vessels. Skull fractures, any sign or symptom of shock. So this is the Center for Disease Control. I don't care what you think about them right now currently with COVID, but they came up with this trauma triage protocol, and it's basically the national standard now. So I'm going to break this down into chunks so that we can see it easier. The first part is physiological. How are they responding to their anatomical injuries? Right. So glass scale less than 14. So that they're off 2 points. They're a little confused and they only open their eyes when you talk to them. That's a fairly significant change in mental status. Systolic less than 90. Ideally, you look at a MAP, mean arterial pressure, and you want that to be between 60 and 65 as a minimum. Respiratory rate less than 10, greater than 29. Now, Portsmouth Hospital did their study to become a level 2, then they found that in the 2 years prior to that event, every trauma patient that died in their hospital had a respiratory rate of 30 or greater. That's bad, right? Respiratory rates 12 to 20 are normal. So think about that. Well, he's hyperventilating. Yeah, he is, but why? Is he hyperventilating because he's anxious, because he's in pain, or because he's in shock and his body's trying to convert lactic acid into carbonic acid into water, heat, and CO2? Okay. So any one of those is a yes, you go to a trauma center. If not, you look at anatomy. Those are the penetrating injuries, the flail segments, the long bones, crushed, degloved, or mangled extremities, those amputations, pelvis fractures, skull fractures, and paralysis. Any of those are yes, you go to a trauma center. If those are no, you look at mechanism of injury, your falls, your crashes, your motorcycles, your pedestrians, okay? Any of those, you go to a trauma center. If the answer is no, you look at special considerations, age, over 55, higher mortality rate in motor vehicle accidents. Remember the fact that in geriatrics, we talk about the 1% rule. After the age of 30, organ systems on average lose 1% of effectiveness. So now you're 25 years down the road, your organs are basically 75% effective. Okay? Kids should be taken to kid centers. Anticoagulation and bleeding disorders. So they're on blood thinners, not one baby aspirin a day either, by the way. We're talking the Coumadin warfarins or the Eliquises, things like that, okay? Time-sensitive injuries, eyes, hands, amputations, etc. Dialysis patients. Pregnancy over 20 weeks, because in theory at 20 weeks, the fetus is viable. In theory, right? The last one I love, your judgment. You look at physiology and go, no, that's okay. You look at anatomy and go, well, no, there's nothing really I can put my finger on. You look at the mechanisms of injury and you're like, well, it's kind of borderline. And you look at special risks and you go, well, but just something, there's something I don't like about this. Okay, take them to a trauma center. Okay? Because also, when in doubt, transport to a trauma center. Secondary assessment, our rapid trauma exam. Right, head to toe, head, neck, chest, belly, pelvis, legs, arms, and back. Look for your blood at the meatus, right at the penis and the vagina, right? The urinary meatus. Do we have blood coming out of the belly? Do we have rectal bleeding? Do we have priapism on that man? Right? Rolling your car over and getting ejected should not be sexually stimulating. You should not have an erection. That's the way I look at it. And if you do, it's a priapism. Okay? Baseline vitals. This says baseline vitals en route. That's crap, because unless you can't maintain an airway, or you can't maintain breathing, or they are bleeding to death in front of you, we need baseline vitals, because that sets the trend for us. Right? 10 minutes later in the truck, you might have okay vitals, but you can't recognize the fact that they were really good vitals 10 minutes ago and we're trending down. So while I'm doing an assessment, I got somebody getting vital signs for me. I want them as soon as I can. We're not delaying things. Sure, if you bring the monitor out and do it, and the monitor goes, oh, failure, no, do a freaking old school, get a blood pressure cuff and a stethoscope and listen. Okay, it's faster. Head to toe, so a detailed exam en route if you have time. We need a medical history if we can get one. Monitors are great. 12 leads are good. Capnography is fantastic, as appropriate going down the road. Early notification. If I decide today that I'm going to the trauma center at Portsmouth, even though I have an hour and 10 or 15-minute ride, I'm getting on the phone with them right now. This first chance I have for just a 10-second phone call. Hey, it's Kevin with Action Ambulance. I have a trauma team activation. We're an hour and 10 minutes away. I will call you in 20 minutes with an update. Click, and it just gives them that warning. As far as packaging, right?
spinal motion restriction. If you have a super sick patient and you have multiple extremity fractures, yeah, you can put them in that scoop, put their legs together, use straps or tape, strap their arms to their sides. That's okay. Um, Femurs, though, I like to do femur splinting. It doesn't take that long, with a Sager or with one of the Kendrick devices. It might take you a minute. And the reason I like to do that is the first traction splint was invented during World War One. Dr. Thomas, the Thomas Heffring. He did a study, and he found that 80% of the femur fractures on the battlefields of World War One died. 80% of them. You got to remember, big vessels around that femur. So he developed this half ring traction splint, and it was 20% afterwards. So simply applying a traction splint went from 80% mortality to 20%. And people say, well, Kevin, that's not very realistic. It's a battlefield. It's trench warfare. It's hours and hours. Yeah, but we're moving this patient. They're moving them through trenches and up over berms, and they're dragging them through mud hole. Well, we're dragging them out of fields and out of river banks and out of ditches, and we're bouncing down the road in trucks over frost heaves, and so I don't know, traction splint. Reassess them every 5 minutes. You're going to a trauma center, reassess every 5. If you don't need to reassess every 5, then you probably don't need the trauma center. Look for your trends. Okay. Call them 20 minutes later and say, hey, this is what I got. And in my case, I got an hour and 10-minute ride. I still got 45-minute ETA. I'll give you a call when we're going over the Sullivan Bridge and into Newington. I'll give 10 minutes out. I'll give you another update. Okay. Keep in mind that these folks are at extremely high risk for shock, and that you've got different types, different levels of shock, right? Compensated shock. Blood pressure's okay, but they're starting to compensate. Decompensated shock. Don't forget that. Recognize compensated shock. Their skin's cool and pale, right? Because they're shutting off blood flow to the skin. They're a little tachycardic. They're a little tachypnic. Recognize that and go, maybe we should go to the trauma center. We need to maintain cellular perfusion. We do not want to pour a ton of fluid into them. We do not want to crank their blood pressure up. We want to give them just enough fluid to keep that blood pressure at 80 or 90, that MAP at 60 or 65, okay? They have to have enough volume, but that volume has to have enough red blood cells to carry oxygen, okay? All of that goes into blood pressure, adequate pressure. They have to have an adequately sized vessel, right? If they're vasodilated because of a spinal cord injury, you can pour a ton of fluid into it and maybe fill it up, but you know what? Your neuro patient probably needs a paramedic and some Levophed, okay, to try to make those vessels a little smaller also. Once we have controlled hemorrhage, if it's external, then we can start pouring some fluid into them. Let me repeat that. Once the hemorrhage is controlled, if you have uncontrolled hemorrhage and you pour fluid into them, you are making pink water in their veins. Okay, that pink water does not carry oxygen. It does not carry platelets. It dilutes everything, and they end up not clotting, and they end up dying. Okay, I'm going to put up another video on this lethal triad at some point here shortly, but 500 ml boluses, recheck their blood pressure. If their blood pressure is okay, don't give them any more fluid. So here, MAP. So what's mean arterial pressure? It takes into account the fact that we have systole and diastole, right? So systole, systolic blood pressure. Diastole, diastolic blood pressure. Diastole lasts twice as long as systole. Therefore, it's twice as important in figuring out perfusion. So if we take the systolic blood pressure, 120, and we add that to the diastolic times 2, right? Because it's twice as important. So 120 over 80. We have 120 plus 80 plus 80. So 120 plus 160 is 280. Now we divide it by 3. We have 28 divided by 3 is going to be 90, let's call it 92, okay? That's great. You have 100 over 40. That's 100 plus 80 is 180 divided by 3 is 60. That's minimal, okay? So again, IV fluids, they need to be warm fluids because we don't want to make them cold. We need to be careful with how much we give them because we don't want to dilute their blood and make them bleed. We also don't want to give them 2 or 3 or 4 liters and crank their blood pressure up because now they're going to bleed to death faster, okay? They need whole blood and they need surgery. So titrate blood pressure, 80 to 90. The other way to look at MAP is if you have a monitor. You put the blood pressure monitor on them and it says 120 over 80. The little number in the middle, 92, is the MAP. Excuse me, that's my water bottle. Now, absolutely, 2 big IVs. And when we say large bore, 14s and 16s. Yes, you can give blood through a 20, but blood will go through an 18 faster, and it will go through a 16 significantly faster, okay? If the blood pressure is low, give them 500, recheck the pressure. If it's still low, give them another 500. Okay? You've got to keep them warm. It's August, we're sweating our asses off. We get in the back of the truck with them, we turn on the AC. Well, guess what? They cannot control their body temperature anymore. They've lost that thermogenesis, all right? So you've got to turn the heat up. Heating blankets, because otherwise they end up in coagulopathy, which is clotting disorder where they throw a ton of little clots out. The body goes, oh crap, that was bad, and sends out all of its own TPA, tissue plasminogen activator, which is the clot buster. It sends it out, breaks down all the clots. Now the platelets are used up, the TPA is used up, and they just start oozing blood everywhere. And they die, okay? Keeping them warm, keeping them oxygenated, and not dumping a bunch of fluid into them helps keep them alive. So starts with scene size up and then progresses to our primary assessments and then to our management of those threats, then our rapid trauma exam and treatment of those things. ABCs, March, like I said, I love March, massive hemorrhage, airway, respiration, circulation, and hypothermia, okay? Keep them warm. Blood pressures, like we've just talked about. On scene, managing on scene time, minimizing on scene time. If I can fix it, I will fix it. If I can't fix it, it's time to go. So if they have internal hemorrhaging, I can't fix that, it's time to go, okay? If they have a bad airway, there's a good chance I can fix that, so I will fix that, okay? Do not delay transport for IVs or to splint wrists and forearms and ankles and tib fibs, okay? Like you already know how I feel about the whole femur thing though. Well, we need an IV in case he crashes and we won't be able to get one. Okay, so what? Drill him, right? You drill him with an IO and you basically have a central line anyway, so who cares? Okay, get your ass on the road. Can think about helicopters, right? If you're 25 minutes from a trauma center and you're 25 minutes from a helicopter, it probably doesn't make a lot of sense. All right, so Multitrauma. Thank you for your time today and visiting with me in the cave, which is a little bunk room they built in the garage here at work. Anyways, this will be up on my YouTube channel here pretty soon. If you have any questions, shoot me an email. Love to chat about it. Take care.